Imagine you're assisting in a delicate eye surgery. You reach for a standard piece of sterile surgical gauze to just, dab away a tiny drop of fluid.
Right, something you do 100 times a day.
Exactly. But as you handle that woven cotton pad, a single microscopic piece of lint breaks free, and it falls right onto the exposed lens of the patient's eye. You can't even see it.
No, it's totally invisible to the naked eye.
But that tiny speck of cotton is enough to trigger this massive cascading inflammatory response, a response that could actually blind the patient permanently.
Yeah, the margin for error in that room is effectively zero. I mean, that microscopic piece of lint perfectly illustrates why the operating room operates under a completely different set of physical laws than anywhere else.
Oh, for sure.
The physical layout of that room and the specific composition of literally every item in it is the only thing keeping biological chaos at bay.
Welcome to today's deep dive. Whether you're a medical student prepping for your clinical rotations or maybe a young surgical professional looking to sharpen your reflexes, or honestly, if you're just insanely curious about how the hidden world of the OR actually functions.
We're going to unpack the physical logic of surgery today.
We are. And we're drawing today from the Ultimate Roadmap for Scrub Personnel. It's called Surgical Mayo Setups, second edition by Tammy Alhoff and Debbie Hinton. I mean, this text is practically the survival guide for surgical technologists and nurses.
It really is. And our mission today is to move beyond mere memorization for you. Because, memorizing a list of tools won't save you when a procedure suddenly changes direction and a patient's vitals drop.
Right, memorization goes out the window.
Exactly. We are looking at the underlying mechanisms. We want to master the why behind the physical architecture of the sterile field. Because when you understand that underlying mechanical and, biological logic, you can anticipate a surgeon's needs before they even open their mouth.
You essentially become an active, essential extension of the surgical mind. So, okay, let's unpack this by starting at the absolute center of the surgical universe, the Mayo tray.
The famous Mayo tray.
Yeah. Most people picture this giant table full of tools, but the primary workspace is actually remarkably small. What is the mechanical logic of this specific tray?
So the Mayo tray is this flat stainless steel tray, and it slides into a specialized height-adjustable stand. And its defining feature is its cantilevered design.
Which means it kind of hangs over, right?
Yeah, the base of the stand slides under the operating table. That allows the tray itself to literally hover immediately over the patient, directly in the sterile surgical field.
Wow, right in the action.
Right, and that hover is critical. Because space right above the incision is incredibly limited, the Mayo tray can only hold the most immediately and commonly used instruments.
The absolute workhorses of the procedure. We're talking about things like a #3 knife handle fitted with a 10 or 15 blade. And we have Metzenbaum scissors, which I want to pause on for a second.
Oh, the Metzenbaums.
Yeah, because to a layperson, scissors are just scissors. But Metzenbaums are fundamentally different from what you keep in your desk drawer, aren't they?
Oh, absolutely. They're specifically engineered for dissecting delicate tissue. They have this, really elongated handle and a relatively short, fine blade.
So the handle is way longer than the cutting part.
Exactly. And that ratio gives the surgeon incredible mechanical advantage and control. Plus, the tips are usually curved and blunt rather than sharp.
So they aren't just snipping things blindly.
No, the surgeon uses them to separate very thin layers of tissue, almost like peeling apart layers of an onion without accidentally slicing into the underlying blood vessels.
And speaking of blood vessels, the Mayo tray is always loaded with basic hemostats. And these aren't just standard pliers. They have a very specific locking mechanism, right?
Yes, the ratchets. If you look near the finger loops of a hemostat, there are these tiny interlocking teeth.
Like little gears.
Right, so when a surgeon clamps a bleeding vessel, they squeeze the loops together, and those teeth lock the jaws shut with a really precise amount of pressure.
Oh, so they don't have to keep squeezing it.
Exactly. The surgeon can literally let go of the instrument and stays clamped. It stops the bleeding while they just, move on to work on something else.
That's brilliant. But, the Mayo tray isn't operating in isolation. It's supported by the back table, which sits further away from the operating table.
The warehouse, basically.
Right. The back table is essentially the warehouse. It holds everything else, the massive retractors, the extra sponges, all the specialized gear. And keeping the flow between the warehouse and the active Mayo tray requires immense organization.
It's heavily choreographed.
Yeah, and the Alhoff and Hinton text highlights the roll towel method. Can you explain the physics of that? Like, why are we rolling up towels on a metal tray?
It's actually a brilliant piece of ergonomic engineering. The scrub person literally rolls up a sterile surgical towel tightly, right?
Yeah.
And they place it horizontally across the Mayo tray.
Okay, creating a little bump.
Exactly. They then use that elevated bump to prop up all those ringed instruments we talked about, the hemostats, the scissors. By resting the hinges on the towel, the finger loops are angled perfectly upward in the air.
Oh, I see. So when the surgeon calls for a clamp, you aren't trying to, like, pry a flat piece of metal off a flat metal tray?
You'd fumble it every time.
Well,
No, you
yeah.
just hook your fingers right into the loops and pass it in one fluid motion.
Because it's already sitting up waiting for you.
Exactly. It shaves fractions of a second off every instrument pass. And in a surgery that requires hundreds of instrument passes, I mean, those fractions of a second add up to less time the patient is under anesthesia.
Wow, that's huge. The text also mentions bringing in a secondary Mayo tray, which honestly seemed counterintuitive to me.
How so?
Well, if space is already at a premium hovering over the patient, why crowd it with a second tray?
Well, you only really see that in massive open cavity procedures, like an exploratory laparotomy where you have to hold the entire abdominal wall open.
Okay, so a much bigger surgical site.
Right. For that, you need something like a Belfour retractor. And a Belfour is this heavy, multi-part steel instrument with ratcheting arms and wide blades. I mean, it takes up a massive amount of premium real estate.
So you can't just toss that on your delicate little Mayo tray with the scissors.
No way.
Yeah.
So you introduce a secondary Mayo tray strictly to hold that heavy hardware. It keeps your primary tray clear for the fast-paced, delicate instrument passing.
That makes sense.
You'll also see ring basins, these sterile metal bowls on stands, pulled up nearby to manage sterile trash or hold really large tissue specimens.
Okay, but let me introduce some friction here, because this setup, it sounds meticulously engineered for a perfectly flat, horizontal patient.
Like a textbook diagram.
Exactly. But bodies aren't uniform, and neither are injuries. So what happens if the patient's anatomy or the room layout just doesn't allow for a standard Mayo stand to be rolled over them? Let's say you are operating on like an extended arm or a wrist.
Well, what's fascinating here is that the physical furniture has to adapt to the anatomical reality. The standard setup is not some rigid dogma.
So they just ditch the tray.
Basically, yeah. In an arm or wrist procedure, sliding a Mayo stand over an outstretched limb is clumsy, and it actually risks bumping the arm.
Which would be catastrophic.
Right. So the scrub team will often pull the large back table directly up to the sterile field. They just use it as a continuous massive workbench right next to the patient's hand, entirely bypassing the traditional Mayo stand.
Oh, wow. So the spatial architecture adapts to the physical skeleton of the patient. The rules are the same, but the layout changes.
Exactly. Keeping workhorses close and specialty tools back remains the core philosophy.
Let's take that a step further, because the tray also has to adapt to the biological reality of what is happening inside the patient.
Right, the tissue level.
Yeah. In general surgery, specifically operations involving the digestive tract like an abdominoperineal resection, we are opening the abdomen. We're using heavy-duty tools, Richardson retractors, for example.
Those are crucial. A Richardson retractor has a sturdy right-angle blade with a curved lip.
It looks kind of like a garden hoe, almost.
That's a good way to picture it. It's designed to grip and pull back thick, dense layers of abdominal muscle and subcutaneous fat. That way the surgeon can actually see the organs beneath.
Right. And you also have your Kelly clamps and your DeBakey forceps. But the gastrointestinal tract introduces this massive biological hazard. And to me, here's where it gets really interesting.
The human bowel is essentially a contained ecosystem, and it is teeming with bacteria.
Good bacteria, usually.
Right. Inside the digestive system,
Yeah.
that bacteria is highly beneficial. It's essential for life. But if even a microscopic drop of that intestinal fluid escapes into the sterile peritoneal cavity, the open space of the abdomen, it becomes lethal.
It triggers peritonitis, right? Systemic sepsis.
Exactly. It's an instant, massive infection.
Which brings us to the bowel technique. The text calls this the clinical firewall. And I want to play this out logistically.
Okay, let's do it.
I'm the scrub tech. We are deep into a colon resection. The surgeon finally cuts into the intestine to remove a diseased section. In doing so, the scissors, the forceps, the clamps they just used, they all touch the mucosal lining of that open bowel.
Yes.
Suddenly, half the pristine, expensive steel tools on my Mayo tray are biologically hazardous to the rest of the patient's body. So how do you successfully close the patient up without dragging that bacteria through the pristine abdominal wall?
You have to execute a hard pivot halfway through the operation. If we connect this to the bigger picture of patient outcomes, the scrub person is essentially managing a dirty surgery and a clean surgery simultaneously.
Wow, at the same time.
The clinical protocol of the bowel technique dictates that the moment an instrument touches the mucosal lining, it is instantly considered legally and clinically contaminated.
So what happens when the surgeon finishes the anastomosis? Like once they've successfully stitched that open colon back together, sealed the leak, and stabilized the bowel,
The firewall goes up. Every single instrument, sponge, or needle holder that came into contact with the open bowel is completely isolated,
you just pull them off the tray?
banished. The scrub tech takes them off the working Mayo tray entirely. They're typically placed in a designated dirty basin and removed from the immediate field. They are dead to you. You do not touch them again.
That is intense. And for actually closing the patient?
The scrub person must have anticipated this from the start. They will have a completely separate, pristine set of clean instruments reserved strictly for wound closure, sitting safely back on the warehouse table.
Just waiting for the end.
Right. Fresh scissors, clean tissue forceps, new needle holders for the sutures.
That takes so much planning.
It does, but it goes beyond just the metal. The text emphasizes that the surgical personnel who had their hands directly in the contaminated area may need to physically step away.
Wait, really? Like
Yeah.
leave the table?
Just step back, strip off their contaminated gowns and gloves, and re-scrub into fresh protective equipment before they even attempt to touch the clean closing materials and stitch up the abdominal wall.
Wow. It is literal biological containment. You are tracking the microscopic status of every piece of steel on your tray.
Every single one.
And since we've established how the tray adapts to that biological contamination, I want to look at how it adapts to sheer physical extremes.
Okay, the big macro shifts.
Yeah, because if we compare a cardiovascular procedure like a CIBG, a coronary artery bypass graft, to an OBGYN procedure, it is like looking at two completely different planets.
The spatial requirements couldn't be more different. I mean, in cardiovascular surgery, you are opening the massive cavity of the human chest and rerouting the hydraulic blood supply of the heart.
It's massive engineering.
It is. The interventions require macroscopic life support systems to be integrated right into the sterile field.
The equipment list is staggering. I mean, you have an oscillating sternal saw, which is designed specifically to cut through the hard breastbone without slicing the soft heart muscle underneath.
A critical tool.
You have internal defibrillator paddles to shock the heart back to life directly. And you have these specialized scissors, the Potts-Smith scissors.
Oh, those scissors are a great example of mechanical adaptation.
Right.
Potts-Smith scissors have blades that are actually angled at 45 or 60 degrees from the handle.
So they look kind of crooked.
Yeah. And this allows the surgeon to insert the tip into a pressurized, delicate blood vessel and cut sideways. They can extend an incision without having to awkwardly twist their wrist or kink the artery.
That's so smart. But because you have all this heavy machinery, plus the massive tubing for the heart-lung bypass machine, the standard hovering Mayo tray just completely fails, doesn't it?
It does. It simply cannot hold the volume or the weight.
So what do they use?
You have to swap it out for the Mayfield table.
What's a Mayfield table?
It's this giant, heavy-duty overbed table. It's built to handle the sheer weight of cardiovascular gear.
I picture it like operating a massive concert grand piano. You know, you have a huge soundboard, all the pedals, total access to everything at once.
That's a great analogy.
But then you switch specialties to an OBGYN procedure like a vaginal hysterectomy. Suddenly, the patient is in the lithotomy position, legs elevated in stirrups. It's like you've been handed a compact travel keyboard.
Exactly. The posture is totally different. The space is incredibly restricted, but you still need total, absolute efficiency.
So how does the tech even fit in there?
Well, the physical posture of the patient entirely dictates your architectural limits. In the lithotomy position, the surgeon is seated or standing right between the patient's elevated legs.
Right.
There is literally no physical space to slide a Mayo stand over the patient's torso. The stand's post would completely block the surgeon's mobility.
So where does the scrub tech put the tools if there's no Mayo stand?
They often work entirely off a back table that is pulled up really close to the side. Or they use very small, specialized drop trays.
Just adapting to the space.
Exactly. And the tools themselves abandon the heavy machinery of the chest. In OBGYN, you are navigating natural, highly restricted canals. You rely heavily on gravity and leverage rather than brute force.
For instance, the overweighted speculum.
Yes, perfect
I was
example.
reading about that. It has this heavy lead ball on the handle.
Well, it does. The surgeon inserts the blade into the vaginal canal and simply lets go.
Just lets go of the instrument.
Yep. The heavyweight hangs down and it uses gravity to effortlessly retract the vaginal floor. That frees up the surgeon's hands entirely so they can work.
That's genius.
And scrub techs will often stretch a sterile surgical glove over that heavy-weighted end.
Wait, why a glove?
It creates a makeshift waterproof funnel, so any surgical fluids hit the glove and are directed cleanly straight down into a kick bucket on the floor, keeping the surgeon's lap entirely dry.
I love those little hacked solutions. You'll also see uterine sounds, right? Which are these long, malleable metal probes.
Right. They can bend to match the unique curvature of a patient's anatomy to safely measure the depth of the uterus, without puncturing it.
Now, I was looking at the genitourinary setups too, the GU stuff, like a cystoscopy where they run a scope up into the bladder. I don't fully understand the physics of this environment.
That's very unique.
The textbook describes a specialized cystoroom, and it stresses the use of continuous irrigating fluids and specifically non-conductive lubricants. Why are they suddenly so concerned about the electrical conductivity of their lubricants?
It's all because of the scopes. In a cystoscopy, you are working through a tiny camera inside the bladder, which is a closed, dark space. To see anything, you have to pump fluid in to expand the bladder walls.
Like blowing up a water balloon.
Exactly. But if the surgeon finds a tumor, they use an electrosurgical tool threaded right through that scope to actually burn the tissue away or stop bleeding underwater.
Ah, electricity and water. That sounds like a bad mix.
Very bad. If you use a conductive fluid or a conductive lubricant to slide the scope in, the electrical current from the cutting tool could travel backward,
Up the fluid.
up the metal scope, and severely shock the patient's urethra or even the surgeon's eye.
Oh, wow. That is terrifying.
So the ecosystem requires non-conductive fluids like sorbitol or glycine and specialized non-conductive gels. It is a completely different set of physical laws.
So we've navigated the massive expanse of the chest and the wet, restricted environment of the pelvis. Let's zoom in even further. Let's look at the micro specialties: orthopedics, neurologic surgery, and ophthalmology.
Micro level.
Yeah, this is where the instruments reflect extreme physiological sensitivity. Although orthopedics, frankly, sounds like aggressive carpentry.
It kind of is.
I mean, power drills, oscillating saws, bone tamps to hammer grafts into place, curettes to violently scrape bone marrow.
Orthopedics is incredibly mechanical because bone is structurally very dense. But, that density hides a terrifying biological vulnerability.
What kind of vulnerability?
Bone does not have the rapid, robust blood supply that soft tissue does.
So it can't deliver white blood cells quickly to fight off an invader.
Precisely. If bacteria get introduced into, say, an artificial knee implant or a repaired femur, the body cannot easily fight it off. The bacteria actually form a biofilm.
A biofilm? Like plaque?
Sort of. It's this slimy, impenetrable fortress that grows right on the metal hardware. And antibiotics often can't penetrate it at all.
Oh, man.
Yeah. A single microscopic breach in sterility can mean subjecting the patient to another massive surgery months later, just to violently extract the infected metal hardware.
Which totally explains the extreme sterile paranoia in the text. The team frequently does a full 10-minute surgical scrub, which is far longer than a standard case.
Oh, yeah, much longer.
They wear double gloves. They wear these specialized surgical hoods that look almost like spacesuits to ensure not a single skin flake drops into the wound.
Every particle is a threat.
But the most interesting rule to me was about the power drills. The text explicitly mandates that these high-powered mechanical drills must never be submerged in water during cleaning.
Yes. Comes right back to that biofilm risk.
Mm.
Surgical drills have microscopic internal gears. If you submerge a drill in a basin of water, the fluid actually forces microscopic biological debris like blood or bone dust deep into those internal mechanisms.
And you can't just wash it out.
No. Even when that drill goes into the high-heat autoclave for sterilization, the heat might bake that debris onto the gears, but it might not completely destroy the bacteria trapped inside it.
You are essentially creating a Trojan horse that will dump bacteria into the next patient's bone.
It's a huge risk. You have to clean them very specifically, usually with aerosols or wipes, never submerged.
That is terrifying. Okay, so orthopedics is an all-out war against bone infection. Let's pivot to neurologic surgery. Craniotomies, opening the skull to access the brain, or laminectomies on the spinal cord. What is the primary mechanical enemy here?
In neuro, the primary enemy is hemostasis, controlling the bleeding.
Which is hard in the brain, I'd imagine.
Very. The brain and spinal cord are incredibly vascular, but you cannot use the mechanical solutions we discussed earlier.
So no hemostats.
Definitely not. If a blood vessel in the brain is bleeding, you cannot aggressively clamp that soft tissue with a ratcheting hemostat. Brain tissue basically has the consistency of soft pudding.
Okay.
Crushing it with a steel clamp causes permanent, irreversible neurological damage.
So how do you stop the bleeding using only what is on the Mayo tray?
You rely on chemical and physical agents. Your Mayo tray must be stocked with bone wax, for example.
What's bone wax?
It's exactly what it sounds like, a sterile beeswax mixture. When the surgeon cuts the skull bone, the marrow inside the bone bleeds. You literally physically smear that wax right into the bleeding bone edges to plug the holes,
Like spackling drywall.
basically. You also use strips of gel foam, which is a porous matrix often soaked in thrombin. You lay it on the brain, and it acts as a scaffold to force the blood to clot rapidly.
And the text heavily emphasizes cottonoids. These are tiny, specially designed neurosponges with little strings attached to them, right?
Yes, they are absolutely vital in neuro.
And the scrub tech must keep these cottonoids meticulously moistened with saline in a basin on the Mayo tray before passing them. I was trying to picture this, and it made me think of a wet paper towel.
A wet paper towel.
Yeah, if you stick a wet paper towel to a glass window, it peels off easily. But if you let the sun bake that paper towel bone dry, it literally cements itself to the glass. You try to pull it off, and it just rips into shreds.
That is exactly the mechanism at play. The brain cortex is incredibly fragile. If the surgeon applies a dry cottonoid to a bleeding section of brain tissue, the sponge will absorb the blood and instantly adhere to the neural tissue.
It glues itself on.
Yes. When the surgeon attempts to pull that dry cottonoid off a few minutes later, it will literally tear the brain tissue away with it, causing catastrophic new bleeding and actual brain damage.
So the moisture is a mechanical barrier.
Exactly. It prevents adhesion.
So what does this all mean when we take it down to the absolute smallest scale? Ophthalmic surgery, eye surgery, cataract extractions, repairing corneas.
A micro level.
This takes us back to the scenario we opened the deep dive with. The text outlines material rules for eye surgery that ban standard surgical materials. You cannot use regular woven cotton gauze.
No, absolutely not.
You have to use pre-cut cellulose sponges, which look like tiny little spears on sticks. Why the ban on cotton?
This brings us right back to the unique vulnerability of the eye. Woven surgical cotton is highly effective for absorbing blood in, say, an abdomen, but the mechanical action of cutting or handling woven cotton inherently releases microscopic particles of lint.
And if a piece of lint falls into a massive abdominal cavity, the body just absorbs it or walls it off with a tiny bit of scar tissue. Nobody even notices.
Right, it's harmless there. But the eye is a closed, pressurized, highly transparent optical system. If a microscopic piece of lint floats into the anterior chamber of the eye during a cataract surgery, the body violently attacks it.
It treats it like an invader.
Yes, it triggers a massive inflammatory response. Granulomas form. These are aggressive clusters of immune cells that cause devastating scarring.
So the patient can lose their vision entirely over a literal piece of dust.
Precisely, which is why everything must be lint-free.
The text even states that before an eye surgery begins, the surgical team must rigorously rinse their sterile gloves free of glove powder.
This is a huge deal. Historically, manufacturers used fine powders, like cornstarch, to keep sterile rubber gloves from sticking together in the packaging so you could slide them on easily.
Right, like putting on dish gloves.
But in ophthalmology, if a single speck of that glove powder falls onto the exposed cornea, it acts just like that piece of lint. The immune system goes into overdrive, causing irreversible corneal damage.
Wow.
The scrub tech is a last line of defense, ensuring that every instrument, every spun, and every gloved hand is entirely free of particulate matter.
It really fundamentally shifts how you look at the room. I mean, the Mayo tray isn't just a piece of metal holding shiny tools. It is a highly engineered, totally dynamic system.
It has to be.
For all the medical learners listening, let's synthesize what we've unpacked today. The surgical setup must instantly adapt to biological infection risks, like the bowel technique, where contaminated tools are permanently isolated behind a clinical firewall.
Right.
It adapts to spatial limitations, like the lithotomy position forcing the complete removal of the Mayo stand in favor of back tables and gravity-weighted instruments. And it adapts to extreme microscopic tissue demands, requiring moistened cottonoids in neurosurgery and lint-free, powder-free materials in ophthalmology to prevent devastating tissue damage.
It is the ultimate manifestation of form following biological function. The elite scrub professional doesn't just memorize the names of the tools on a list. They master the physiological realities of the patient's specific tissue and translate that reality into the physical arrangement of the instruments in their hands.
Which brings us to our clinical review exercise for today. We want you to put yourself directly into the OR. Listen carefully to the scenario. You are scrubbing in for a low sigmoid resection. Halfway through the procedure, the surgeon finishes the bowel anastomosis, meaning they have successfully sewn the open digestive tract back together, sealing it, and they are preparing to close the abdominal wall.
Okay, critical moment.
What specific protocol must you initiate regarding your Mayo tray, your closing instruments, and your personal protective equipment before handing the surgeon the closing suture?
You need to engage the firewall. First, you must completely isolate all instruments, sponges, and tools that came into contact with the mucosal lining of the open bowel, permanently removing them from your Mayo tray.
Get them out of there.
Second, you must introduce a completely separate, pristine set of clean instruments from your back table, reserved solely for wound closure. And third, you and any surgical personnel who work directly in the contaminated field must step back and completely change your gowns and gloves before touching the clean closing materials.
If you visualize that perfectly, you are thinking exactly like a master of the sterile field. But before we wrap up, we want to leave you with one final provocative thought to mull over.
It's something to look forward to.
Yeah, we spent this entire deep dive talking about human hands organizing physical steel instruments across a stainless steel Mayo tray. But we are rapidly moving into the era of advanced robotics, like the Da Vinci surgical system.
It's changing everything.
When the primary surgeon steps away from the operating table entirely, sitting at a digital console across the room while robotic arms interface with the patient, how does that fundamentally force us to redesign the traditional 20th century Mayo tray setup?
That's the real question. In the next 10 years, will the scrub professional's role shift from being a physical instrument passer to a manager of complex digital interfaces and robotic armaments?
It is a profound shift in the very definition of the surgical field. We are watching the physical architecture of the OR evolve into a digital architecture.
The blueprint is literally changing right before our eyes.
So the next time you step into an operating room, remember, you're not just looking at stainless steel furniture. You're looking at a living, breathing ecosystem. Keep questioning the physical setup, keep anticipating the physiological mechanics of the next move, and we'll see you on the next deep dive.